فيروس 2. ما رح نحكي عنه تفاصيل، بجوز جمال يتطرق لها الامور هاي كلها، بس رح احكي بالبدايه انا بشكل عام على الديسيز، رح اكون سريع شوي نوعا ما واحاول اختصر. زي ما بنعرف الترانسميشن تبعه يعني transmitted by respiratory droplets in the air and it is deposited on surfaces. There is a rule about fecal oral routes also as a transmission, and the vertical route of transmission can't be ruled out at the moment. يعني ما يمكن ما في إلا حالة أو حالتين اللي ثبت إنه ممكن يكون vertical transmission، بس بشكل عام الحكي اللي موجود إنه ما بينتقل بالبلاسينتا. كثير من الحالات بين عندهم positive sputum and fecal samples للفيروس even after pharyngeal swab became negative. الviability تبعته it is viable and remain viable and infectious for hours in aerosols and days on surfaces. وكلنا شفنا هالفترة الأشهر اللي مرت، في ناس قديش بيحكي على البلاستيك بيضل، قديش على الكرتون بيضل، قديش على الفلوس بيضل، يعني كل هالأمور it's a new virus وكل واحد قاعد بيطلع نظرية يمكن بعد أسبوع تتغير الحكي اللي حكاه. امبارح لسه عمالنا نسمع ريبورتس من فرنسا إنه المياه اللي تستعمل في ري الحدائق والهاي والمياه الراكده بالبرك يعني they found coronavirus 2 SARS coronavirus 2 لقيوا فيها، فالامور كل ما لها بتتطور شيء جديد. Asymptomatic transmission is very very important and this occurs usually during incubation period and can be peaked on or before symptoms of onsets. في الدراسات اللي انعملت على الفيرال لود لقيوا انه calculated infectiousness begins 2 to 3 days before symptoms of onset and it peaks around 0.7 days before symptoms begin. This is very, very, very important because of pre-symptomatic transmission is accounting for about 44% of secondary cases. وهون بيجي خطورة الموضوع صراحة، خصوصاً في بلادنا. خطورة الموضوع إلنا إحنا معشر الأطباء، عمالنا بنسمع كثير حكي عن إعادة فتح العيادات عندنا هون بالأردن يمكن في مناطق أخرى. هذا الموضوع
هيثم لو سمحت في طلبات.
نعم
هيثم إذا سمحت لي في طلبات من المشاهدين إنه اللغة تكون باللغة الإنجليزية حتى لأنه في من خارج البلاد.
Okay, sorry. So this is the pre-symptomatic transmission is accounting for about 44% of secondary cases, and this is very, very serious, especially when we are going to repractice in our clinics because of the risk of exposure to persons who are asymptomatic. The incubation period usually is around 5 days, and in 97% of those who develop symptoms, they will do so within 11.5 days of infection, but it usually ranges between 2 to 14 days. There is what we call a reproductive number, which is RO, or which is how many patients you can infect if you have the coronavirus 2. It ranges from 1.3 to 3.5, and it is double that of influenza. The coronavirus enters the host cells through what we call spike S proteins, which is binding to the angiotensin converting enzymes 2, ACE2. It is a membrane-bound aminopeptidase highly expressed in the lungs and the heart. This invasion mainly to the alveolar epithelial cells, it results in what we call respiratory symptoms seen in COVID-19. Patients who have hypertension and heart disease and chronic lung disease or other immunological deficiencies are at higher risk for severe disease. There was a great talk, a great debate about patients who are taking hypertensive, who are taking angiotensin converting enzyme inhibitors or ARBs, that they thought that this is a very serious disease on them because they have much higher number of ACE2 inhibitors, but this has been rejected and it is now not a concern. As I said, the presentation, how patients present usually, most of the cases, if we can say more than 80%, they are asymptomatic. And only patients, when they present either with acute respiratory disease or they may have atypical clinical presentation. The presentation usually either mild, moderate, or severe viral pneumonia. So the primary presentation is usually as influenza-like illness with lower respiratory tract symptoms. Fever is important clinical presentation. 87 to 98% they developed fever. It is either prolonged or intermittent. It may be absent at presentation. And it has been noticed in a Wuhan study, with a place where they had higher number of cases, that 44% only they had fever at presentation, but it develops in 89% during their hospitalization. So is a very important factor. It may be very severe and often non-productive, and it progresses gradually with the development of pneumonia. Some cases they have hemoptysis, which is either due to lung involvement or due to irritation from severe cough to the airways. Again, an important presenting symptom is shortness of breath, which is usually progressed to become very severe with the development of pneumonia. Other symptoms, such as constitutional symptoms, may occur: myalgia, headache, fatigue, sore throat, nausea and vomiting, diarrhea. These GI symptoms usually develop in some cases prior to the development of fever and lower respiratory tract infection symptoms. In some cases, they have conjunctivitis, which is in fact similar to the other coronavirus, mild coronavirus that you usually have. They present with previously as mild common cold. Neurological symptoms can occur in 36% of cases, and it varies from acute cerebrovascular accident, skeletal muscle injury, headache, decreased level of consciousness, seizures, encephalopathy, agitation, confusion. And an important clinical entity is the development of anosmia, loss of smell sensation and loss of taste sensation has been noticed to the level that American Academy of Otolaryngology and Head and Neck Surgery pointed this clinical finding in their recommendation that we have to take care once this develops. It may indicate the development of COVID-19. If we go to the physical examination usually non-specific vital signs, it might be normal in early part of the disease, but you might find once the disease is progressed, you might have fever, increased respiratory rate, increased heart rate, and the most important thing is the decreased oxygen saturation. Physical finding of the lung usually normal unless pneumonia or ARDS develops. If we go to the labs, again, non-specific laboratory finding. You may find lymphocytopenia, thrombocytopenia, increased liver enzymes, increased CRP, increased ESR, increased albumin, and increased LDH. An important factor is that they notice that the troponin T, which is increased in some patients, and it reflects higher mortality in patients with elevated troponin T levels than compared with patients with normal levels. If we go to the imaging, as usual, we do chest X-ray. Chest X-ray might be normal, but it might show us also bilateral ground glass abnormality. The most important radiological investigation is the chest CT scan, and which is the high resolution chest CT scan. That means CT without contrast. Again, it might be normal in 58% of cases, but usually we have what we call bilateral ground glass opacity. Once the disease progressed, they will have it, instead of ground glass opacities, it became bilateral patchy shadowing with paving stony grid-like thickness of the septum. The clinical course of the disease, it is acute respiratory disease. We may lead to and progress to bilateral pneumonia, leading to acute respiratory distress syndrome, ARDS, and finally to death. The problem is that there is a diffuse alveolar damage, which has been identified in post-mortem histopathological finding of the lungs of patients with COVID-19. The inflammatory response is usually mononuclear cells. It's the CD4, CD8, natural killer cells, and macrophages. If the disease progresses, around 20 to 30% of hospitalized patients, they will need ICU admission. And this deterioration usually occurs in the second week of the illness. And it has been noticed in Wuhan studies, in Wuhan cases, that ARDS developed in 17 to 29% of patients. And the median time between initial symptoms of onset to ARDS was 8 days. In a retrospective case series in Italy, large series, around 1,591 critically ill patients, 99% of these patients, they required respiratory support in some sort or another. 88% of them, they went into endotracheal intubation, 11% they went into non-invasive ventilation. And their ICU mortality was 20%. The cardiac injury is an important prognostic factor in these cases. And as I told before, the troponin T is a common among hospital patients with COVID-19. And it is associated with high risk of in-hospital mortality. Another important marker is the increased antiphospholipid antibodies. That's it, anticardiolipin and anti-beta-2 glycoprotein. And it has been noticed that such patients, they don't have the typical ARDS symptoms that we usually see in patients with, for example, H1N1, because of this increased antiphospholipid antibodies, they develop multiple pulmonary infarcts, multiple PEs, and they die from pulmonary embolism due to shunting. If we, there is an important thing in this disease that we start seeing some series about it is the reinfection, as I hope Dr. Jamal Wadi will tackle on this issue. It has been noticed here in Jordan for 1 case, and in West Bank for 2 cases, with 2 cases, and in South Korea, I think they have 117 cases, what they call reinfection. Is it a real reinfection or other issue? Dr. Jamal might trigger this point. How do we identify cases? We have, in such environment, we have to consider SARS-CoV-2 infection in any person who has symptoms of acute lower respiratory tract infection, that's to say fever, shortness of breath, cough, requiring hospitalization. We have to notice that other co-occurring viral infection have been reported in up to 60%, which is a high figure of patients diagnosed with COVID-19. Detection of other respiratory pathogens does not rule out SARS-CoV-2 infection. We have to take this point in consideration, particularly we are at the end of the season, but we might have this next autumn, next winter, next spring, that we used to see a lot of influenza cases, particularly H1N1. So not to forget, if we find patients with H1N1, to say that's H1N1, no, we have to do specific tests for COVID-19, because currently it is not included in the respiratory panel we usually do. It might be included later. So we have a priority because we lack diagnostic tests. The kits are not available widely in our region, I think, in some countries of the region. So there are priorities who to test. There a priority 1 for hospitalized patient or patient with symptomatic healthcare workers who work in hospitals. There are different priorities for different cases, and this is usually set by the government and by local health authorities. The standard diagnostic technique is taking a nasopharyngeal or oropharyngeal swab or aspirate, although it's risky, and do what we call real-time reverse transcription PCR, or specifically for SARS-CoV virus, CoV-2. The specificity of this test is high. That's to say that positive result, it is likely to be true positive, but the sensitivity is lower. That's to say that a negative result, meaning may be repeated in person who later diagnosed as positive. So we had 1 case here in Jordan, maybe a few days ago, that he did a test here in Amman and it was negative, went his home to Erbil, and next day or the same day proved to be positive by another test. So we have to be aware of the negative results. There are a lot of serological tests they are developing. SARS-CoV-2 serology testing is now available, but on a limited scale, I think. It reflects a prior exposure to the virus, and it can't be used to dependently diagnose current infection. There is a cross-reactivity with other human coronavirus, so we have to be aware of this. So understanding of this serology is still evolving. We need more data. You might hear about the rapid test. It's either for antigen or for antibody. And again, this is still developing. So once patient admitted, diagnosed, he needs a treatment, and this is mainly a supportive care. The most important thing is the implementation of infection control measures. We have to do standard supportive management of respiratory disease and complications, including advanced organ support if indicated, for example, heart failure, renal failure, or what else. An important issue here is the corticosteroid. We pulmonologists, we like corticosteroids so much. So if it is not ARDS, unless requested, we need to give it for a specific issue, for example, septic shock or diseases such as exacerbation of COPD, do not use corticosteroid because it has been noticed that it is prolonged viral shedding. We have to encourage non-intubated patient as well, not patient on ventilator, even non-intubated who are hypoxic. We have to encourage them to assume a prone position when this is practical. So once patient is in the ICU, the issues of arterial blood gases, acid-base balance, hypoxemia, ARDS management, hypercapnic respiratory failure, mechanical ventilation issues, sepsis, vasopressor, all of these issues came into account. So if patient having ARDS, so we have to, it is in the States and in some other countries, they start using hydrochloroquine, and I'm sure that Dr. Jamal will elaborate more on this issue. It is in the state, I think, allowed only for hospitalized patients with pneumonia, but no suggestion for or against its use in outpatients or in hospitalized patients without pneumonia. Again, we have to concentrate on prone ventilation. Before that, we have to remember that this is an important drug, hydroxychloroquine, for connective tissue disease patient. And once it is not available for any reason or other, these people, they will suffer a lot. So we have to encourage, again, prone ventilation for ventilated patients, especially who have refractory hypoxemia due to the progressive COVID-19 pneumonia. And if they are not responding, we might go what we call to extracorporeal membrane oxygenation, ECMO. And this is a practice in some countries. It was practiced in China, in USA, and some other countries. A lot of medication has been tried, antiviral, lopinavir, ritonavir, there are interleukin-6 receptors blockers, as you heard a lot about these. We have the remdesivir, and we have antiparasitic also, which is the ivermectin. It is an antiparasitic, sorry, with antiviral property. It has an in vitro inhibitory effect on SARS-CoV virus 2 replication. Still, all of these are under trials, and still no definite drug of specific benefit. So we have to, once patient is in the ICUs, they have to be managed with shock hemodynamic support. IV fluids is the main treatment. It should be used conservative fluid administration strategy, not liberal strategy. We have to concentrate on crystalloids over colloids of using in patients who are hypotensive shocked, using norepinephrine as first-line vasoactive substance. If it is not available, we can go to epinephrine and vasopressin. Dopamine is not recommended for these patients. The ventilatory support, usually we supplement them with oxygen to keep, if they have oxygen saturation below 90, just to keep their oxygen saturation level around 96%. If they fail this, we have another options, which is high flow nasal cannula oxygen, if it is available. If it is not available, we may try a non-invasive positive pressure ventilation. Again, there was a great debate about this, but now it is considered one method of oxygen delivery, and it is allowed in such patients. Once our patient, they are on ARDS, on mechanical ventilation, we have to make sure that our setting is appropriate. This is a nightmare dilemma, and we have to consider different things. We have to use low tidal volume, 48 ml per kilogram predicted body weight, and we have to use a high PEEP strategy. For moderate to severe ARDS, again, prone ventilation, 12 to 16 hours per day. Not to be liberal with the neuromuscular blocking agent, it is as needed instead of continuous in order to facilitate protective lung ventilation. Again, back to the corticosteroid, if we have ARDS, it is allowed and you might use it. Of course, these patients, they might have secondary bacterial infection, and we have to carry on empiric antibiotic agents, but we have to assess for de-escalation once this is feasible. Fever should be used antibiotic. There is a lot of talk about convalescence plasma, and this has been tried in Wuhan. When 5 critically ill patients, one study, they improved due to that this convalescent plasma containing and neutralizing antibodies. It is again used for research purposes in the States, and there is a way how to collect from which patient and when to collect, a lot of ethical issues. You may heard about remdesivir, شركة جلعاد company, which their revenue increased 2 days ago once they announced that they have some success. Still, we have to wait for another 2 to 3 weeks to have a response. Personally, I don't think this is a great drug or there'll be a major. I don't know if Jamal might comment again on this. So finally, how to reduce risk of viral respiratory illness? It's just, we have to concentrate on wash hands with soap and water for at least 20 seconds. If soap and water are not available, we have to use alcohol-based hand sanitizer containing at least 60% alcohol. We have avoid touching our eyes, nose, or mouth if this is possible. I don't think it's feasible for each one of us. We have to avoid the close contact with people who are sick and stay at home when you are sick, and cover your eyes, cover your mouth and nose when you are sneezing. We have to adopt, and we're starting to adopt for social distancing. For this, I finish my brief presentation and going back to Jamal.
Thank you, Dr. Haitham. Let's welcome second speaker, Dr. Jamal Wadi Al-Ramahi. He will talk about perspectives in COVID-19. Welcome, Dr. Jamal.
Thank you. تعطيني الشاشة يا سيد علي.
وصعب تشوفها يمكن جمال.
اوكي شفتوا الشاشة الآن؟ ايوه. Do you see the slides?
Yes, we can see the slides.
Okay.
Yes, Dr. Jamal, you can start with slides.
Okay. Now this is the laser. What I'm going to do with you now, I'm sorry for this topic. It seems that something else that is a slide. However, this talk will be perspectives in COVID-19 or SARS-CoV-2. Remember, it was named initially 2019 in Wuhan, so the names are changing. I was in the corridor of one of the hospitals, and one of the employees about 2 months ago or more, that's 1 month ago, he's showing me this result for one of his relatives. I told him this is, well, nothing but the usual coronavirus. Not every coronavirus is that highly pathogenic, causing mortality, ARDS, etc. Most of them, like 229E, HQ1, LS3, and OC43, they are the usual viruses that circulate. But this one, OC43, this is the virus that speaks for the ancestry of the other, viruses. Sorry, it seems that I'm sorry for this. I have to stop the slides now. These are not the slides. لأنه بجوز دقيقة واحدة بس. The beginning is the same, but lectures. It seems that's because I had several talks this today and yesterday. So this is the one here, perspectives. Yeah. Sorry for this mishap, and we'll start now. Okay. So that's the slide that you saw initially. And now in this talk, I'm going to answer a few questions that you may want to ask me or ask the panelists in general. Are we late in action, WHO preparedness, epidemiology, virus survival, drug therapy, and mask at the end? And this is, I explained that.
So Jamal, but if you can reshare the screen because we cannot see the slides.
Excuse me?
If you can reshare your screen again, because we are no longer seeing your slides.
I am sharing it now. Oh, you cannot see it? Let me see.
We cannot see Dr. Jamal, please.
Yeah, I know, but I was sharing it and I can see you. Let me see here. Share screen. And let me see. Share again. You can see it now?
Yes.
Yes,
Yes.
yes.
Yes,
No,
we
you
can
can't.
see.
You cannot see or you can see?
No, we can see it.
You can
We
see
can
it.
see Dr. Jamal. You can
So we
continue,
are
yes.
back on track, and this is the laser part. Remember that's the other slide I mentioned here, this virus OC43, the one that causes infection. That's the common ancestry for the severe viruses that we have. Now, how these viruses really evolve over time. Remember, as a member of the National Committee, we investigated several outbreaks in the past. One of them was SARS-CoV-1 here, and we are SARS-CoV-2, what we call COVID-19. And remember the MERS-CoV that started in Zarqa in Jordan, and it went like a wildfire in Saudi Arabia and nearby Arab countries. So the origin of it mostly is bat. Whether the bat comes in contact with the Arabian dromedary, then from the saliva goes to human as the final host, causing MERS-CoV, or the bat come in contact with an animal like big cat, which is a very ugly one with small legs. It's called civet. This civet, again, if it comes close to human, it may transmit the SARS-CoV-1, which is the classic SARS of 2002, 10 years ago. And now the bat came in contact with something called pangolin, which is, as you can see, a lot of scales. And again, in China, people, they come in contact with those animals and they eat those animals. Now, response and detection to avoid, people, they started blaming and claiming that China and that Jordan, that United States, they are late in discovering whatever they have. Honestly, this is not the case. The reason for that, because whenever you have an outbreak, there are steps you follow. You cannot jump from one case all the way to declare pandemic immediately the next day, the next morning. So you have to go through steps, and we're not going to go through them. However, this is the scientific way of doing it, and you have to prove it and to define the case and to go systematic analysis, and then and evaluate yourself, re-evaluate self, and do some teams, what's called FTPEs, field trained epidemiology personnel to go into the field to get more cases from hospitals, from people, and then declare either endemic or epidemic, or even pandemic, like what happens lately. And here we start, as everybody knows, here is the Huanan, where Wuhan is present as a city with about 11 million inhabitants, and Hubei was hit hard. And then here in the East Coast as well, Zhejiang, she was hit hard with the SARS. But those cases here, in an article was published a couple of months ago, it was milder cases than Wuhan. And this phenomena, thank God, is that it's clear for viruses as they go into cell passage, they become attenuated and weak. This is one of the studies that initially Dr. Haitham, he alluded to, is that the study that initially, very initial, how they get around and know there's a problem. They have one case of unusual infection that comes to the ICU. And then 2 cases plus 1 case. Why 2 cases plus 1 case? This case, it was in Huanan seafood. If you remember at the beginning of the news, they claim seafood is transmitting the disease. But actually it seems bat to pangolin, to others, to human to transmit the disease. And then after those 1, 2, 3, 4 cases, silence of about a week, and then 2 cases in the seafood market. So they discovered there's something unusual, and they did within a month, they did epidemiological alert, and the market was closed in January 1st. It was totally shut down by the Chinese authority. And this slide, our slide, the previous slide is this one. This is the slide before. And you can see here, as the days go on, cases increase dramatically, like parabolic in nature. And here in this light yellow, this is the lunar month of the Chinese. They start celebrating, cases, they become horrendous. And here, they stop celebration Chinese, they a little bit dipped down, then went up again all through. And here the temporal or time relation, when they stopped the seafood market, when they did shut down of that's in January 23rd of Wuhan city, and of course other 15 cities were shut down. And here in January 30th, which I don't think it was late, it was declared a public health emergency of international concern for all the country to be aware. So what is different this time? In the past, we have SARS 2002, and now we have SARS-CoV-2, which is COVID-19 in 2020. Look here, just simple. I'm not going to details of the slide. November to July, I remember that. I was a member of the committee and we investigated one case or two cases. From November to July, a lot of cases occur in SARS-CoV-2, but the total number in China only until July were 5,300, outside less than 3,000, death 350 around, and 400 outside. That's until July. But this COVID-19 from November to February, which is 1, 2, 3, 4 months, or sorry, 3 months, you have 74,000 infected, 2,000 deaths, and outside China, that much of people died. So there is something new, some other virus. Now in Jordan, what's happening in Jordan? Let me just focus in Jordan for our colleagues who are watching from outside as well, to see what's the problem. Here in Jordan, you can see as cases build up, initially, we have a case, which is this one. It was 2nd of March. We have a case here. Let me just move this video from in front of my face. March 1st here, and then silence. The same phenomena like what happens in China. And then, look here. In March 20th, we had 85 cases. There were 70, plus 15 on that day. Then we have 85 cases. Now, look to this. At that moment, we of course, we have been in meeting from here, not from here, from the first, even before the first case, we were in meeting. And total curfew was done in Jordan for those days, 1, 2, 3, 4, 5, 6, initially. Nobody moves around on the streets, total curfew. And then after March 26, partial curfew was all through. And then here, and the first mortality in Jordan was on 20th of March, which is, she was a lady, 83 years old, and she was very comorbid, and she died in the hospital. And at that moment when she died, there was 151 cases in Jordan. So mortality rates, thank God, is low. So what happens from the, formal point of view, then because of this mortality and the partially, the authorities here do total shutdown on one day here, then weekend and every weekend almost they were shut down. You can see the curve as this cumulative curve as it went, and we worked hard not to make it what's called parabolic. If you can see this thin black line that I'm going through, this is calculated by computer. It's called polynomial line. It gives you the trend of cases. So our case trend should be up, but we managed to bend it down a little bit to 389 cases. And now, last week, last week, 10 days, became 413 cases we became. So that's the story of what's happened in Jordan. Now, worldwide, you can see different countries, they have different rates. Total cases in 100,000. Look here. Total confirmed cases without outbreak. If you can see different countries here, the legend, France, or in green, Spain, or Germany, and on the other side, you can see the mortality. Look at the end. That's April 15. Look here, the mortality. You can see clearly Belgium even supersedes Spain, not Italy. So it's a dynamic process that is changing. I am not in the business of too much curves and numbers because people they forget that. I called my slide a déjà vu. That's I saw it from before. it means that the symptoms that this disease, Dr. Haitham mentioned about that, nothing unique, cough, fever, dyspnea, etc. So nothing unique about this. And remember, this is from the 41 very early study, from Wuhan that published in the Lancet initially. So the same is valid until now, no change. And those are the timeline between 41 individuals who are infected 100%, and how many days to be admitted, to have dyspnea, to have so-called, I don't know, ARDS or ARDS-like picture, and ICU admission. So it means there is, there is hiatus between here and here, I mean, the event. This study followed the previous one by Guam, published in New England, again in February 2020, and it was published on 1,099. Remember, the first one was 41. And look, interesting things, even for Dr. Haitham and the chest community. You can see here in severe diseases, very severe disease, you may have 3% of patients, they don't have X-ray or CT abnormality, no algebra at all. In non-severe cases, maybe 18%, 17.9, they don't have it. And of course, the other symptoms, the same, nothing. And they noticed in Wuhan that 72%, they have contact with residents of Wuhan. So even those who are outside Wuhan, they have contact with people over there. And this is the X-ray, you can see 2 patients, one and the other one. So there are honestly nothing fancy about these X-rays. Dr. Haitham أكثر مني بعرف بالموضوع هذا. They are nothing but infiltrate. They call it ground glass appearance, infiltrate, disinfiltrate. So not unique to this group of people. And they try to look for other things, comparing patient less than 15 days and after 15 days of shedding the virus. Why people they shed the virus more than the others? They found that male sex, it speaks for significantly for shedding the virus. Old age, significantly, not as significant, but significant. I don't know why hypertension. Hypertension, I thought it was something called lurking variable or lurking of a confounder, but it seems hypertension, again, it's a variable that is associated with late shedding more than 15 days with individuals. Whether this is lurking variable that hypertension comes in the elderly, old people, and again, they are collinear with this, it's called, or not, I don't know. Delayed admission, again, it speaks for more RNA shedding. Severe illness, mechanical ventilation, and steroid therapy to some extent, this speaks for that. And what is different again? In supplies, you can see machines, respirator, handkerchiefs, visors, masks, wipes, tissues, all of them, they vanished from the market because of this Mr. Virus that they have. If you notice the 2 colors here, S1, S2 protein, and the E protein underneath here, and of course inside the nucleoprotein inside the virus, you cannot see it. Now, let's go to some next issue about management and treatment. Unfortunately, people, when they hear a name of a drug that has been in our literature for years, experimental, and they think it is the great savior for humanity, it will save. Of course, we love to have a drug that saves us and treat and make it easy for us. But however, look at this study. This study was done in cell research. And using remdesivir, chloroquine, they say effectively inhibit the recently emerged novel coronavirus. But again, let me warn you, a journal of cell research, and that's their cell research. You can see here the curves now. Here, you have to, please, to switch your mind, the way you think. The more you go, it's negative, it's inhibition. Down is positive. Cytotoxicity, the more you go, it's more cytotoxic. So what happens is if you use ribavirin or nitazoxanide, which is anthelmintic, or penciclovir, which is antiherpetic, a good one, which is favipiravir, anti-flu, IV, nafamostat or camphostat, chloroquine, remdesivir, all of them, if you notice the curve, as you increase the concentration in micromole, they do inhibition of the virus. This is inhibition. And this is cell death or cytotoxicity. You have to balance between inhibiting the virus and not killing the cell. That's in cell research. And they used what's called here, look here, VOE6, E6. Others, they use ATCC cells, different types. But however, this is still research. And you can see here, for ribavirin, for others, they inhibit quite well the virus. And those squares, cytotoxicity, which is low, as you increase, it's still low. But here, nitazoxanide was toxic, remdesivir not toxic, chloroquine not toxic. Now, to prove this concept more, you can move all the way to the right. You can see here, this is the MSO, the preservative. This is chloroquine, different concentration, and remdesivir, different concentration. You can see here, nucleoprotein stain. And here, Hox stain for the cells. And you can see, this is simply the placebo or control, let's put it control. You can see a lot of cells here infected, a lot of cells infected, because they incubate the cells with the virus. Now, if you increase the concentration from 0, nothing is infected. Now, cells green infected, and the blue cells viable with viruses through them is less than here, less than the control. And as you increase that concentration to 3.3 micromole and increase more, you can see even the virus hardly ever seen inside a cell or a cell. And the same with remdesivir again, the same phenomena, nothing is different. The other point that people keep on asking, virus survival, reduction, what will happen? How long does it live? Honestly, I cannot answer this question, but we can have a speculation how long does it live on surfaces in the drop, etc. Here, look at here. This, it's advances in virology in 2011. It was done on, again, a coronavirus, SARS-CoV-1, which is very similar to our virus, reduction of viral titer. Again, here, 0 equals 10 to the 5, and these are number reduction in viral titers by log. I mean, 1 log, 2 logs, 3 logs, 3.5 log reduction. Look here, look at the red one, the red line, and the blue line. If in red, the virus in solution, or dry, and relative humidity is 40%, like sometimes our environment at ACs inside building, and temperature is 20-25, it's like building ACs. Again, let me scare you a little bit. You can see the virus, it lives, reduction of the virus is low, 1.5. Even in day 13, 14, up to 21, you can see still there are viable viruses. About 0.5 log or 1 log is still viable virus. But if you increase humidity to 95%, and you use temperature 33, temperature 38, you reduce the virus dramatically. You reduce the virus. So higher temperature, it does kill the virus, decreases activity. But again, they reach here, we don't know about whether it reached to 100%, which is 100% reduction. So that's how we answer this question. Let me jump over this. Now, effect of temperature and humidity, here temperatures 38, 33, 28. The two different colors, 95% humidity. This is 80, 85%. And you can see, and this is a viral reduction, titer reduction. You can see the same like a previous curve, but this is split into different temperature and two other humidity, 95 and 80. You can see here still there's viable, very viable, up to 24 hours here, 24 hours, 24 hours, 24 hours for all different temperatures and humidity. Now, the article that kills me, honestly, and kill everybody, as soon as I read the article, it was a manuscript. Before publication, I got it as manuscript. You know, before you send a paper for publication, sometimes they post it as a manuscript to be seen by others, other researchers, to criticize or something like that. Excuse me. This by Raoul Didier, our friend, our colleague Didier from south of France, Didier and his group. What did he do? He says, well, hydroxychloroquine and azithromycin as a treatment of COVID, and everybody started dancing and yelling, and now we have a treatment. Nobody pay attention to the study, to the supplementary data that comes study. He used only, after calculating the power of the study, he could get 48 patients. He couldn't get them all. He got only 36 patients. Combination therapy, if you can see here, azithromycin treatment plus hydroxyl treatment, yes, they were only 6 patients. So we are going to change the world over 6 patients. And second thing, in PCR, something called CT, which is cycle threshold. If you are above 35, it's negative. بعكس ما بتتوقع. If it's less than 35, it's positive. So he caught in his study positive and negative and not done. But when it comes to positivity, look here, it's positive, low. It means positive. He put the number. He did not put it positive or negative. So honestly, there was some dishonesty in the way this article was presented. And this graph, I was so mad one day because people start sharing the graph alone. And even this graph, if we know some case in the for those are using, it was not significant, the change, then maybe it's not significant, then very significant, very significant, very significant, very significant. And everybody start congratulating the other on the green hydroxy and azithromycin does the best of killing the virus. Actually, analysis of the article this way is wrong. It should be analyzed in a different way. He analyzed every 3 points, what's called by ANOVA independently, which is wrong, false. Those numbers, for example, let's take the black line. Each point in the black line is dependent on the other. This one is dependent on this. On the blue line, this is dependent on this. He should analyze it by something called independent numbers and not independent. That's different mathematical. I'm not going to confuse you with this. Different methodology, which I did it myself, honestly, something called Mankova. It showed no significance. I was happy that there is Andrew Lever, biomedical statistician from Massachusetts. He did analysis. The same, you can refer to the literature, by the way, Andrew Lever, and this article, you can see it. And he says there's no significant effect of this combination based on what Didier gave us. The second thing, remdesivir. Remdesivir as a drug, it's RNA nucleotide. It goes derailment or cuts the RNA of the virus. And what is used? It was used in a small study again, and it was used. I did some red lights here. It was used as compassionate use. Honestly, when people jump from country to country or continent to continent, it changes from compassionate to what's called SOC, standard of care, which is false. This is not standard of care. It's still compassionate for study by whatever. Now there are studies going on for that. I know one in Turkey, one in the United States, and one by WHO called the Solidarity Study using remdesivir, ritonavir, ritonavir, plus hydroxychloroquine, 3 arms. So far, the studies are not encouraging at all until well-controlled studies. And they used remdesivir in oxygen saturation of 94 or less, so in very severe cases. And he concluded in his conclusion that some people, they got better, some people they're not. But we don't have another arm to compare. How could we tell that those some people you are telling me are due to drug effect rather than spontaneous? Give me 2 arms, I will tell you. Those are not 2 arms, but he is comparing the non-invasive disease with invasive disease, and this is age groups, and this is total. So honestly, okay, maybe slight effect, I don't know, but however, we have to wait for that. Again, people, they jump to ivermectin, which is again anthelmintic drug, like nitazoxanide. And again, in lab, look here, relative RNA drop, great. Now, this is not inhibition, this is copy drop. And this is, as you increase whether you are looking for E antigen in the cell or E antigen in the supernatant or the fluid of the cell, or cell-associated RDRB, which is RNA-dependent RNA polymerase gene, or gene you find with in cell, not in tissues, not in mice, not in rabbits, and sure not in human. In cell, the RNA drops down, and there is good effect of the drug on those in cells, but so far not in animals. Now I'll move to simpler way, infection control. Nothing fancy, nothing different. The same WHO recommendation, the same IDSA recommendation, the same European recommendation, Japanese, Chinese, our recommendation, everybody recommendation. If you have a disease that زي ما حكى الدكتور هيثم that be transmitted with droplets to some extent, you need to wash your hands or use sanitizers. Avoid touching your nose, your mouth, your eyes, because a drop in your finger on the mucosa, you can get the disease. When you cough, use your sleeves or a handkerchief. Avoid coming close to people, social distancing, very important. Again, disinfectant everywhere. And the most important in this outbreak, stay at home. So staying at home in Jordan and other Arab countries worldwide, except this so-called Trump, that he is so late, was so late in implementing this, and to some extent North Italy, unfortunately, and some European countries, staying at home is one of the single most important factors to do social distancing and not to transmit the infection if one person to the other. And I'm sure you know, all of you know this slide, put it in TV, one person, how much he infects within a day, within a month, sorry. And if you are away a little bit, less, away, less, and you're at home, you are not infecting anybody. Now, maybe this is the last slide or the one before, about masks. Again, something honestly killed me in the streets here in Amman, Jordan, and I don't know elsewhere. People, they put on themselves this blue mask, and they tell me, well, this is a local factory doing it. It costs about $30, $35. It's N95. This is not N95. This is hoax. This is not N95. This is called the cloth mask. A cloth mask are useless. And this study was published in British Medical Journal, I think in the year here, in 2015, not now, comparing a cloth mask with N95 with the surgical mask. You know, the surgical mask that everybody knows, the simple surgical mask, the standard surgical mask. And look what happens. This is a good study, honestly. I describe it honestly. It's a very good study. Look here. You can see here, access for LGBT, 15 hospitals. They kicked out one hospital because it was not eligible. Randomized 1,100 healthcare workers, used medical masks, cloth mask, and control. The control, they tell the healthcare worker, well, if you have influenza, you have somebody with CMV, you have somebody with Epstein-Barr virus, or the usual corona. We didn't have COVID, SARS-CoV-2 then. Just behave whatever you want. Just put the mask, you don't the mask, that's up to you. But those in medical, they should be medical masks. And this cloth mask, they must do the cloth mask. And they analyze it. And the numbers you can see are pretty similar. What happens? What happens? They looked at respiratory illness. That's the endpoint, influenza-like illness and so on, and fevers as well in the healthcare worker, and see what happens. Eligibility, all nurses or doctors, full-time. Anybody who refused or removed the mask, or he has a long beard, he was excluded, or big mustache, he was excluded. Not because this will violate the integrity of the mask. And what happens? Look here, beautiful. Clinically diagnosed cases, if you can hear the cloth mask, the rates of infection was 7.6% attack rate. The control, they were less, and the ILI 4.8. For other viruses, the same. The protection rate for the medical mask was the best. The next best, the control, who did nothing. Then the worst was the cloth mask, and for ILI, influenza-like illness as well. Look here, the cloth mask is doing worse than even without it. And they explain it very well in the article. If you're interested, I'll say, whoever interested, I'll send it to him. And you can just get the name, and you can see it on the web, in Google Scholar, this article. You can see that the cloth mask did poorly, even worse. Don't put it better than putting it, that one. Because the reason for that, because it caused moist. So cloth mask and something called carbon mask, and the other one called carbon and the cloth, and the third one, they are useless. The useful one are the real N95, medical N95, and the surgical mask. The cloth mask, you should not use them at all. And look here, that's their impression. I cut for you so as not to say I modify any statement. This study is the first randomized controlled trial of cloth masks, and the result caution against the use of a cloth mask. This is an important fact to inform occupational health and safety. Moisture retention by cloth causes poor filtration and even worse outcome to the individuals. And thank you. I am done.
Thank you, Dr. Jamal, for this nice talk. We have a lot of questions from a lot of countries. We can start now some questions to be discussed with our two speakers. The first one for Dr. Haitham. When will the vaccine be ready? Dr. Haitham.
Yes. I don't think all of us know that. I don't think it will be ready for months, maybe a year to come. It needs a lot of work, a lot of investigation, a lot of safety issues later. I don't think it will be readily available this year. This is my personal feeling. I don't know what Jamal says.
Honestly, if you look at the 2002 SARS-CoV-1 and MERS-CoV, laboratory research, they really worked hard to get a vaccine. There was no vaccine. Currently, this one, honestly, I doubt, as you said, I doubt there will ever be vaccine. It is going to be maybe no less than in years and years, because some antigens, some viruses, or some antigens, some viruses, they are not immunogenic. Sometimes in the laboratory, what we do is attach to them adenovirus or other particles to make them bigger to induce antigenicity. Even with that, until now, it doesn't work.
Thank you. My second question from Yusuf Zangana, Mr. Yusuf Zangana, for Dr. Jamal. If the same virus infects another person in the same family, is it going to be weakened by the first host and causes less symptoms?
Good question. This is honestly on a person-to-person level. The passage, the lineage passage from one person to person, it is not that greatly reduced. We talk of epidemiology, endemicity. For example, if we have a virus in X city that circulates, then it goes to another city, a third city. A lot of people got infected, and then infected other people from the first lineage. The same one goes on. It became attenuated. This is a phenomenon in even influenza viruses, and that's how, without intervention, that's how the curve goes down on its own spontaneously. But between one family member and the other, I guess maybe in a nano level, but not practical.
Thank you. Dr. Haitham, it's a good question also for you. Can the virus affect the person again? How and why?
And the virus what? Sorry?
Can the virus affect the same person again? How and why?
This is what we call the reinfections. From our experience with the influenza, for example, and H1N1 in particular, it is once patient got it, usually it is a permanent immunity. But there has been some reports, one, as I told you, one in Jordan, 2 cases in West Bank, and in Korea, South Korea, they reported that there are some reinfection. And still, I don't know if this is a real reinfection, or it is a matter of false negative PCR to start with, or other issues. Still needs a clarification. We need some time. This is a new virus. This is a new environment, and we need a lot of data, a lot of study. But generally speaking, in the world of virology, once you get a virus, usually you got a permanent immunity. I don't know if Jamal have another comment.
Oh, I agree with you, Haitham. Honestly, I doubt there is reinfection. Yeah, because it's difficult really to document what's called relapse of the same virus. But usually, some phenomena occurs in the body, elevated temperatures and fever, sometimes 10 days, 20 days after the initial infection. It's like, let's put it this way, like what happens in the brain with some of infection, auto-eczematization or reaction, that causing symptoms after the virus is gone, the immune system will work and causing that. Meanwhile, you do sometimes the nasopharyngeal swab again, and you find it positive. Oh, you said it came back again to me. But I think it's the same. Until we have new data, we cannot make comment against or with.
Okay. The next question is for Dr. Jamal Wadi from Dr. Zainab Abu Aisha from Jordan. Why the infection rate in Europe and USA is different from the Middle East? Is it related to genes or something like that?
Okay, good question. By the way, this question has been in circulation for quite a while now. What happens in North Italy? What happens in Spain? What's happening in the United States? Why they are at large, they got infection. Remember, I think, my humble opinion is that, as I mentioned, people, unfortunately, they took things lightly at the beginning. They think of the conspiracy theory, and this virus is nothing but like flu, and it will subside, just forget about it. And they were hit hard. Now, some theories about the increased mortality in Spain, North Italy, and United States, they say, well, because they have elderly population compared with, for example, Arab countries, mostly are kids and babies. But again, we can speak against that easily. Look at Germany. Germany is more elderly than Italy. We know all of the statistics worldwide. And the mortality rate is only 2%, 1.9%. Meanwhile, Spain and Italy are between 9 to 11%. United States now that's the same, about 6%. So we cannot explain based on this. Now, based on gene theory, even somebody makes jokes why Arabs they are got infected, not as bad as Europeans, different genes, etc. Remember that Mediterranean individuals or patients, individuals, they share a lot of diseases from Spain to South France, Italy, Greece, Turkey, and the Arab countries on the south. And honestly, this theory, whether we have a gene that to protect us, some people they say, well, the ACE receptor, which is not a receptor, the ACE is a co-receptor, is less in us than others. I don't know. No explanation so far, except the laxity that they adopted initially.
Okay, again, Dr. Jamal, there's a question for you. You are talking in your speech about it, but we can ask you again. Washing clothes after work, especially in the medical workers, doctors, pharmacists, hospital workers. What do you think about that?
You mean in case that you have cases in your hospital?
Yes.
Now, if you have a cases, there's a protocol for that. Now, we designed in the National Committee in Jordan, Lajna Wataniya, we really did a job on designing the units, the negative pressure, and the PPEs, protective personal equipments. Now, a healthcare worker must not see those patients, definite diagnosed patient, with their own clothes. There are special overclothes that covers from head to toe, including head cover and the gloves and goggles and surgical masks. And we have them in, at least as I know, specialty and the Khalid hospital, we have them for medical workers when they encounter or possibly encounter a case. Those, they should be discarded there's a pattern of how to discard them. Before going home, you have to remove everything except the gloves at the end. At the end of that, you remove the gloves, just like turn it around like stockings or socks, and you wash your hands. And maybe a good idea, you are right, as soon as you reach home, you put your clothes in the washer. But if you use the PPEs in the hospital, I don't think that's highly needed.
Okay, we can return back to my friend Haitham. The percentage of asymptomatic carriers. Can you have some percentage?
This is most of the patients, they are asymptomatic, and maybe reaching up to 80%. I think with time, once the issue is become more clear, and once we have the serological test or a better rapid test after the pandemic, we might have an idea about the situation much better, about the percentage of people who have been infected in the community, in the country. But as I said, it's still a new virus. All what we have now is just from that one that came from China, and now from Italy, from the state. It's still evolving. Data is evolving. But generally speaking, majority of cases, they are asymptomatic. And even here in Jordan, a lot of cases have been infected and admitted. Once they track them, the patient where their primary source of infection was asymptomatic.
Yeah, thank you. We have a question from Dr. Imtinan Ali. If we have a person infected with H1N1, can he get COVID-19? You have any?
Yes, as I said in my talk, co-infection with other viruses is common.
For both of you.
Yeah, so co-infection with other viruses than COVID-19 is common. May reach up to 50%, or other bacteria or bacterial infection. So as I said, for example, next autumn or winter or spring, once there is again back the influenza season, once you got a patient with influenza positive by any means, by any respiratory panel test, you should, if again, we don't know how the pandemic will go, but we have to think again by COVID and do the COVID test in addition to other respiratory viruses.
But Haitham, if you allow me, usually in co-infection of pathogens of different classes. For example, you can get H1N1 with CMV, with other herpes viruses, but not of the same class. Corona, it's classified as upper respiratory, and usually the usual thing we know, if somebody is infected with COVID or severe influenza, usually the cells which are infected, they're almost the same cells, they secrete interferons preventing others from coming in. That's in general. But honestly, we have to have data from clinical to see at the end.
Thank you. Also for Dr. Haitham, can the virus cause permanent problems for the patients?
Still, we need more data, I think, but generally speaking, once a patient with ARDS, the recovery time usually takes weeks, sometimes months, actually. This is about pulmonary involvement. If it is neurological involvement, the improvement will be much slower, again, maybe months, maybe permanent sequelae. Again, it's a new virus, we have to wait and see.
Thank you. The next question is for Dr. Jamal. It's coming from my friend, Dr. Nisreen Al-Hawamdeh. She is gynecologist. Does the virus affect fertility, sperms, or oocytes for Dr. Jamal?
Let's answer you. It's an RNA virus to start with. And usually, honestly, if during acute phase, this is theory extrapolating from other viral infection, not for this infection. As an RNA virus, cause overwhelming infection, it may be transient but not significant. We can take it from, remember the outbreak that took place in Sierra Leone, Conakry, Freetown in Africa, Ebola virus. It's an RNA virus, almost similar, not similar, but the same concept. It was, the virus was found in the semen of men and the prostate secretion even a few months after that. But clinically was not known that it contributed to sterility, it contributed to transmission infection or not. Here in this virus, SARS-CoV-2, so far no clear data on that, but I guess it's a respiratory virus, remember. It affects mostly cell type that are present in the upper respiratory and the lung, of course, the lower respiratory tract. Though there is an article in the hepatology and gastroenterology, they prove that the virus may be present in feces as well. To some extent, they could find it in few individuals. And the virus may present other secretions, but usually it's a respiratory. So I guess, honestly, that theoretically, it shouldn't do a permanent damage to the men as far as the sterility.
Thank you. The next question is for both of you, please. From Dr. Walid Al-Jirikh, he is an surgeon in Jordan. Can the virus transmit in air? What's your opinion?
May I answer? Or?
Yeah, Dr. Jamal.
Okay.
For both of you.
Honestly, this is confusing. The reason for that, because since the beginning, the virus, زي ما حكى الدكتور هيثم في البداية, at well known, it is by droplets. And we are in infection control in hospitals. We differentiate between the droplet isolation or airborne isolation. Now, this virus is mostly transmitted through droplets, means that it comes out with big macroscopic saliva with coughing or talking to the nearby environment. If you are 1.8 meters, exactly 6 feet or 2 meters, you are safe. Now, within a room, just listen to this, within a room, if a person infected and coughing within a room, in that room, maybe, not sure, but maybe there is a limited, what's called airborne transmission. And that's why in some hospital that I work as a consultant for infection control, I told them 2 departments, we split the AC completely, make it complete different AC apart from the hospital, bumping air to the outside through HEPA filters so as not to return back to the other rooms. So within a room, yes, it may, but on the streets, in the mountains, from building to building, I don't think, honestly, I don't think so.
Dr. Haitham?
Yes, I do agree. سؤاله بيجي لأنه عمالنا بنشوف every now and then.
Yes, please, in English.
Yeah, because I think he asked this question because there are few reports about airborne transmission, but these are limited studies. I do agree 100% with Jamal.
Okay, thank you. The last question is from many doctors and from Dr. Ghassan Talahmi and from me. From both of you, please. Your protocol in treating COVID-19. Let's start with Dr. Jamal.
Okay. We have a few cases in the Malik Abdullah Muassis in the north, a big hospital there, and a few cases in Hamza. Yani between poor cases to intermediate cases to mild cases. Honestly, in the committee initially, they were excited about hydroxychloroquine, azithromycin. I was all the way against it, until now against it, because there's no evidence that really works. And now today, one of my colleagues in the committee, the national committee, Dr. Fasil Bakri, is an adult infectious disease University of Hostel with me and in the university. The IDSA, the Infectious Disease of America, published just about a couple of hours ago 3 trials from China, from even France itself, and I think Brazil. All of them on hydroxychloroquine, they say it does more harm than benefit. So we go back to square one, like what Dr. Haitham said. It is supportive therapy, critical care therapy if you reach to the ICU, ventilator therapy, oxygenation therapy, ECMO, etc. They are the expert in that. And unfortunately, pharmaceutical therapy so far, there is none, unfortunately.
Dr. Haitham?
Yes, I do agree again with Dr. Jamal, but you may add also antibiotic, as I said, if you think of secondary bacterial infection, but you have to de-escalate, yeah, once you have evidence of culture or if the patient improves. But I don't think there is a proper anti-COVID antiviral for SARS-CoV-2.
At the end of this scientific virtual lecture, I would like to thank my friend Dr. Haitham Kushman and my friend Dr. Jamal Wadi Al-Ramahi, all the respected attendees, and all thanks for Dar Aldawa for sponsoring this lecture. And I hope to see you again, all of you, but not at homes, to see you in reality very soon. Please stay safe and good night. Thank you very much. Stay home.
Thank you very much, all of you.
And a very special thanks to you,
Thank you for Abdullah Battah, the members of Dar Aldawa, my friends, all of them, and all thanks for the whole people.
Thank you so much, Dr. Bassam, and a special thank for you for moderating this valuable session. Actually, we have learned a lot from health and experienced doctors from this pandemic, and we hope that we will meet again, either through a webinar or in person, of course. And a special thanks for those who attended all the session. Actually, we have exceeded 800 participants. We get more than 100 questions. So sorry for people who we couldn't answer your questions because we have a lot of questions. We hope that you enjoyed this evening with this valuable information. In the end, thank you, Dr. Jamal and Dr. Bassam and Dr. Haitham for giving us your time for sharing this experience. At the end, I would like to reshare the video of Dar Aldawa that we played in the beginning, so people who couldn't see it, just to see it again. Can you please, Abdullah, share the video?
دار الدواء شركة أردنية مساهمة عامة تأسست عام 1975. تعتبر دار الدواء شركة رائدة على مستوى منطقة الشرق الأوسط وشمال إفريقيا في مجال الصناعات الدوائية والصيدلانية والصحة العامة. منذ تاريخ يمتد لأكثر من 40 عاماً، نحن نتبع نهجاً طويلاً يركز على عملائنا لتطوير وإنتاج وتسويق الأدوية عالية الجودة بأسعار معقولة في الأسواق الناشئة. نتميز بفريق عمل متخصص ذو كفاءة عالية بالتطوير والإنتاج والتسويق، يضم أكثر من 900 شخص في أكثر من 30 دولة في جميع أنحاء الشرق الأوسط وأفريقيا وأوروبا لنصلك حيثما كنت. نلعب دوراً رئيسياً في السوق الأردني بين الشركات المصنعة المحلية. ينبع نجاحنا وأداؤنا من كوننا واحدة من أكثر المصانع الدوائية تكاملاً في الأردن والمنطقة، وهو تميز رئيسي أدى إلى ظهور دار الدواء كشركة رائدة في السوق، حيث اكتسبنا ثقة الأطباء والمرضى منذ تأسسنا. تدير الشركة اليوم شبكة متكاملة من 11 منشأة صناعية منتشرة في جميع أنحاء الأردن والشرق الأوسط. مواقع التصنيع 4 مصانع في الأردن و1 في الجزائر. الجودة العالية هي مفتاح نجاحنا على المدى الطويل، حيث تساهم جميع التقنيات الحديثة وعقود من الخبرة والمعايير الصارمة للجودة الشاملة في تقديم منتجات نفتخر بها. يتم الإنتاج لدينا وفقاً لممارسات التصنيع الجيدة الحالية GMP وآيزو، وتم اعتماد منشآتنا من قبل الجهات الصحية الرئيسية في أنحاء العالم، بما في ذلك مجلس الأدوية الإيرلندي والهيئة السعودية للغذاء والدواء ومؤسسة الغذاء والدواء الأردنية. شركة دار الدواء شركة أردنية مساهمة عامة تأسست عام
السلام.
Thank you so much again. Stay safe, everyone, and hope to see you very soon with a new continuous medical education program with Dar Aldawa. Thank you.
مع السلامة. باي باي.